Well, hello there, and a very pleasant good evening to you all. If this is your first time joining, my name is Dr. Randy Fink, and it is time for Fertility with Fink and Friends. I am Fink, you are Friends, and this is the place to be. Every Tuesday evening at this time, it's 5 o'clock on the Gulf Coast, which means 6 on the East Coast. 4 o'clock in the mountains and 3 on the west. And I am a fertility gynecologist here at New Life Fertility in Pensacola, Florida. We also have offices in Mobile, Alabama, and Panama City. And I also work with the fine folks at the Missouri Center for Reproductive Medicine in St. Louis, Chesterfield, to be precise, with another office in Tulsa. I get to frequent sometimes, and it is great to see everybody tonight. How's it going? I hope this week has turned out is wonderful for you. Happy Cinco de Mayo. And for those who celebrate and those who don't, happy Cinco de Mayo anyway, because there's really no good reason not to celebrate Cinco de Mayo, right? It's another wonderful day. It's as if we need one more reason to celebrate. Good evening, Amber Jones. Thank you very much for the compliment on my haircut. I got actually a couple of them cut. They were offering a special. They would do one for the same price as cutting all of them. So I just decided to take advantage of that. And you know, hey, why not? Yeah, it's a different look. It makes me realize just how little hair I actually have left. But I think, you know, so far so good. I'm going to make do with this one. Let it grow out a little bit. No complaints here. Rosa, good evening. Nice to see you. As always, Princess Surrogate, good evening. And a special shout out to the Bama Gal and her wonderful man who are close together, I presume, in Mobile, Alabama. And that's my mom and dad. Hello, Mom and Dad. Thank you for being here. And happy Cinco de Mayo to you. I'm sure you are doing wonderful things tonight to celebrate, like maybe even getting out of the chair. You know, that's a good start. I'm just saying. Hey to everybody else who is with us tonight, and let's see, I guess everybody's out tonight. We got some folks here. We've got a couple of different Facebook feeds. We've got New Life Fertility. We've got MCRM. We've got LinkedIn. We've got YouTube. We have First Fertility with us. We've got my Instagram page right here, which is Randy Fink MD, and New Life Fertility's Instagram page right here. Point of the whole exercise tonight is throw your questions my way, and I will do everything I can to try to help you get to the bottom of whatever is on your mind as it pertains to fertility, women's health, getting pregnant, staying healthy, and all around just kind of being a good person, you know, because I think that's what life's all about. Not enough good people out there. Actually, that's not really true. There are an awful lot of good people out there, but I will say I don't think there's enough kindness in the world. And so anything that we can do to try to spread some of that love, spread some of that kindness is probably a good thing. And to that end, at 5:30, half past the hour, we do the ceremonial 5:30 Fuzzies with Fink, and that is where we give shouts out and send love to all those people tonight who need our love and affection and who need to know that they are not alone, because that is an important part of what we do here. So let's see. Over in my world tonight, we did a whole bunch of egg retrievals last week. There are embryo transfers this week. We had several people come back already from the last set of transfers doing their OB ultrasounds, which is always my favorite thing, when we get to see what things look like on the ultrasound. And so that's kind of a common question. And that is, what do you expect to see when you look with that ultrasound when I am newly pregnant? Good question. And the answer to that is, well, so the first thing we do when we find that you have that positive pregnancy test is usually that we repeat it. What we really like to see is we like to see that number doubling every 48 hours. And that's the beta HCG, the hormone level. We like to see it double every 48 hours because 2/3 of normal pregnancies will double in 48 hours. However, early on in pregnancy, it doesn't always double. It may just kind of be going up. It may go up by 2/3, and that's still pretty reassuring. So we might get another one as well. But basically, kind of based on that, by the time, if there's any question, by the time your quantitative beta HCG, which is the pregnancy hormone number, by the time that number is at about a 1500, they really technically say 1500 to 2000, we ought to be able to look with a vaginal ultrasound and see that the pregnancy is inside your uterus. That is, that we can make sure an intrauterine pregnancy is there and not a pregnancy that may be in the fallopian tubes, or what we call an ectopic pregnancy. We get very worried about ectopic pregnancies because they are more common in the fertility population. And to be honest, that's not something that we in the fertility business should really ever miss. And in fact, if you see an OBGYN of any sort, then missing an ectopic is generally very frowned upon. So we really try to avoid that. So first thing we may see is just evidence of the pregnancy inside the uterus, because until you're about 6 weeks pregnant, we may not see the pregnancy itself. So by about 6 weeks is the point at which we can start to see the heartbeat. So pretty reliably, 6 weeks and a couple of days, we ought to see a pretty normal heart rate. So the first thing that we go to look for is the pregnancy in the uterus. And when the answer to that is yes, it is, what is the heart rate? So when we first start to see a fetal heartbeat, that number may actually be a little lower. It may be in the 80s or 90s, maybe even 100 on, when you're 5 weeks and 5 days, or 5 weeks and 6 days, or right at 6 weeks. But by the time you're about 6 and 2 or 6 weeks and 3 days, that number is generally between 120 and roughly about 160. When it's not, we kind of want to keep a close eye on that, because a low fetal heart rate at that gestational age can sometimes portend a chromosomal issue with the pregnancy. And so we do watch that one very carefully. But so we look to see the pregnancy, we look to see the heart rate. When we look to see that heart rate and we see that little heart beating, we know that 95% of those pregnancies will continue on without having an issue. And that is the best news that we can hope for. That is what we're looking for. We're looking to see that fetal heart rate. We take some measurements. We measure what's called a crown rump length. The crown, the rump, right? It's what will become the booty, as Marin, one of our ultrasonographers here, says, the booty. We can take that measurement, and that measurement in millimeters actually correlates with a gestational age. So, for example, we did one today, and I believe the patient was about, I think she was roughly about 7 weeks pregnant, and the embryo, or rather the fetus at this point, measured about 1.7 centimeters. And you say, well, gosh, wait, how big is that? My finger from here to here going across measures about 1.5 centimeters. So that 7-week pregnancy is roughly the size, maybe a little bit bigger than your fingernail, which is just incredible stuff. It's really amazing that we can see that. But that's the first kind of what we're looking for. Usually we take some measurements. We look at the yolk sac, which is another structure inside the uterus. It kind of looks like a wedding ring. And I often say, oh, look there, you swallowed your wedding ring and it got inside your uterus. A yolk sac is a normal feature in an intrauterine pregnancy, and then when you would measure the uterus and measure the ovaries, we can see them. Usually, we have you back in 10 to 14 days, and we look to see that the embryo has continued to grow. Most of the time, after that, you graduate from my care and move on to go see your OB. Now, it's, I'm told it kind of depends on where you are, but in a lot of places, it's hard to get an appointment with the obstetrician who's going to take care of you for your pregnancies. Many of them, they may not even agree to see you until 10 weeks or sometimes even 12 weeks. But we generally say once you have that positive pregnancy test, go, we want to keep you so that we can make sure that everything is going in the right direction. But go ahead at that point and make the appointment, because it does sometimes take a long time to get into the OBs. Bows and barbells. Hey, just popping in to say you did my egg retrieval back in 2024, and my miracle is now 13 months old. That is wonderful. Gosh, I love to hear that. Thank you so much. Please send me a picture through Instagram, would you? I would love to see that, and I would love to show the rest of the world about your beautiful little miracle there. Congratulations, and I am so happy that I got to be a part of that. Hi to Marlena and Tiandre. Nice to see you this evening. Shabnam, how are you? Rosa asks, how long after stopping breastfeeding can I suppress with Orilissa to go for another transfer? All right, so when we're talking about suppressive therapy, we're talking about someone who has endometriosis. And endometriosis can be, so, probably most of you watching here are familiar with what endometriosis is, but if not, endometriosis is that process where the lining of the uterus that normally sloughs off when you have a period, instead of going out the door, instead moves up on the inside and implants within the abdominal cavity. Endometriosis can cause a number of problems. It can cause a pain syndrome. Many people are familiar with that pain syndrome. It can cause issues with the anatomy. It can distort the anatomy and create I forgot to turn on my backlight here. There we go. All right. Well, that feels better to me anyway. It can create scarring on the inside. It can affect it can affect your egg quality and can affect your ovarian reserve. It can form collections within the ovaries. That's what we call an endometrioma, also known as a chocolate cyst, because that endometriosis in that collection, in that cyst, it literally looks like liquid chocolate if you were to cut into it. It's old blood. And it can affect the way an embryo implants inside the uterus because it blocks your progesterone. So when we know you have endometriosis, we know that by suppressing that endometriosis, by turning off its hormonal food supply, and that's estrogen, for 60 days, we can very substantially improve the odds of an embryo transfer, your embryo sticking inside the uterus. So that's the rationale behind suppression. Once you stop breastfeeding, you can really go ahead and start suppression at any time, because that suppression medication, Orilissa, will really probably also, suppress any residual prolactin that you have going on because of the way it works in the pituitary gland. So really, you can start that suppression anytime, Rosa. But just remember that what we're after is that we're after you going pretty much as you can right from suppression into your embryo transfer. So I wouldn't necessarily do that suppression until you're ready to do your next transfer and actually get pregnant. So careful what you wish for, right? A special shout out to Pui up in St. Louis. Thank you for being here this evening. Hi, Midgie, and good afternoon to Zinni in South Florida. Great to see you this evening, as always. Tried to, Bows and Barbell said, tried to send some photos, but Instagram won't let me. That's interesting. Thanks so much for your role in making our miracle a reality. Well, it is my pleasure. Thank you. And I wonder why Instagram wouldn't let you send pictures. So maybe it's something in my setting. I'll have to take a look at that. Hey to AF McDwyer, and I have to just also throw a little shout out to Pui in St. Louis, who has one of the most wonderful sushi restaurants I have encountered, and I have encountered a lot of sushi restaurants. That's Sushi Station in the St. Louis area. And if you are there, it is worth a visit to Pooey's Place. For real. Dr. Bartolucci is here this evening on the New Live side. Good evening, and thank you for being here. If you're still around, sometimes people pop on and they say hello, and then by the time I greet them, they're already gone. But thank you, nevertheless, for joining for a short little bit there. And Latura Wellness is here. Amy, good evening to you. And Kelly Lee is here saying, getting some polyps removed soon, and then we'll be looking forward to our sit down with you at the end of the month. Love watching the videos. Well, I love doing the videos, and thank you, Kelly. I do appreciate that very, very much. So polyps, polyps are little finger-like growths of tissue in the uterine cavity that stick up like a tree trunk or hang down like an icicle. A polyp is literally a little fleshy growth. And people say, well, why did I get a polyp? A polyp think of it as like a little patch of weeds is the way I think of it. So every little cell in the uterine lining has think of it as a TV antenna that's on top. It has a receiver or a receptor, and that receptor is looking for the signal that's coming from your hormones, and the estrogen hormone in particular tells that uterine lining to grow. Well, the problem is not that you have too much estrogen going on there, because that would make everything overgrow, but think of it as one little patch has multiple little antennas coming off the same place. So it's receiving too much signal, and that signal is telling it to grow. So you literally grow a patch of weeds. And what do we want to do with a polyp? We want to go in typically with a little instrument, basically, and mow the grass. There's a little instrument we have, either a little pair of scissors that can go and just cut the polyp out. There's another type of instrument that kind of functions like a Pac-Man. It goes and just sort of removes the area. Very elegant ways, pretty straightforward thing, Kelly, in order to remove a polyp. It doesn't cause much in the way of discomfort post-operatively. It takes only a few minutes to do in the right hands, and should be really a very minimal thing for you. So we don't like polyps being in the uterine cavity because, well, a couple of reasons. One, it's what it's telling us is that there is an abnormality in the lining. It's telling us that something is wrong in the receptors, and those receptors, we really need in order to be able to get a pregnancy to implant in that lining. Sometimes those polyps can bleed and cause an issue with, some breakthrough bleeding or bleeding in the wrong time during your cycle, or even very heavy periods can be related to having those polyps. In terms of pregnancy, think of it as a little windshield wiper in there. It may bat an embryo right out of the park, but really what it's doing is it's taking up valuable real estate that pregnancy wants to use to implant, and also is a marker that something is not right with those receptors, and that's something that we want to fix. And so that's why we go and we remove polyps. But Kelly, I hope you're not nervous about it. It's one of the most common procedures we do. Very, very straightforward to accomplish. Oh gosh, that's a good point there. Boson Barbell says it could have gone to the requests folder. I'm going to have to look at that. I appreciate you bringing that up. Thank you. Angelina Foxy, good evening in the great state of Minnesota. Thank you for being here. One of the finest nurse practitioners who attends to broken hearts, a cardiovascular person. So happy you're here. And I understand that you are going to be going on vacation soon, and I hope that's going to be a wonderful time. Marlena says, speaking of suppression, do you have to repeat suppression if you get pregnant, but it turns into a chemical pregnancy or an early loss? And that's a good question too. So when you do that suppressive therapy, we generally think that in most people, that suppression will last you for about 6 months. So let's say that you achieve a pregnancy after suppression, but there's an embryo issue and the pregnancy unfortunately doesn't continue to grow. Do you have to do another round of suppression? I would say if it is within the 6 months of finishing off the suppression, I usually don't recommend that people have to do another round. At that point, we think that that first round probably is continuing to work. Now, if it's been more than 6 months or 9 months or something like that, then start to think, yeah, it's probably worthwhile doing there again for sure. Brandy is here tonight. See you tomorrow for my transfer. Any night before or day of advice? Well, I would say so, Brandy. We are very excited for your embryo transfer tomorrow. And a lot of folks here have fingers crossed for you, my friend. So what do you think? French fries? What's the myth with French fries? Are French fries really a thing? Well, here's the answer to that. And if you don't know what I'm talking about, I'll tell you that people say that going to get McDonald's French fries is what you're supposed to do after an embryo transfer. All right, so there is no science to that. It's certainly a comfort measure, and I say anything that you can do to be comfortable is probably a good thing. So I'm all about it. I think it's a great idea because who needs an extra excuse to eat the McDonald's French fries, quite honestly, unless one falls out of the container and you find it under the car seat, like 6 months later, and it still looks exactly like the French fry that came in the original package. That was fresh, although it's cold and hard. I remember seeing something about that you can try to age them, but they don't actually age. So don't eat the one from under the car seat. And that's just my personal word of advice. But I think it's a great idea to go get McDonald's fries afterwards. But where did the myth there come from? Where did that legend come from? It probably comes from something about the salt, salt probably can make you retain some water, and if you're a little dehydrated or retaining some water, keeping some extra fluid on board may in some fashion be a good thing. So I imagine that's where it comes from. But keep calm and eat French fries, and that's what I say. May I be like a McDonald's French fry as I age. As long as you're not under the car seat, Brandy, then I think that's probably a good plan. Yup. I was once a McDonald's French fry, and now I'm kind of more like a steak fry, from Red Robin or that kind of thing. Used to be that nice little thin McDonald's French fry, but look at me now. I'm practically the entire baked potato now, if you really want to know. So sour cream and all, and I'm talking loaded. Yeah. Green onions, we're talking cheese, we're talking the whole schmear there. Let's see. Hi, Shada. Good to see you this evening, and I owe you an email back. What is the right level of E2, and that's estrogen, and progesterone at baseline to start stim if you've been priming with estrogen? It depends on where you are during that cycle, and yours, I got your message, and I meant to respond to that because if you are doing a luteal phase stem start, then a luteal phase stem start will have an elevated level of progesterone. And that's kind of the most important thing. And we're actually looking for that. And you're asking, why should one have a hemorrhagic corpus luteum if I've been priming for 12 days and technically shouldn't have ovulated? Why corpus luteum cysts? Well, you probably did ovulate. And I think in your situation, having that corpus luteum and doing a luteal phase start makes sense, because what happens there is that the number one dominant follicle has gone ahead and released its egg. And when it releases its egg, there's a whole cohort of other little follicles that are there waiting to get recruited. We actually have two phases of recruitment. And so even if you started stimming with cycle day one, you're using estrogen only now. You're not using the progesterone. So really what that's going to do is that's going to put a pause on the growth of some of the follicles, but you, for whatever reason, you broke through there, and that's fine because this is still a luteal phase stem. And so my guess is they wanted you to keep using your medication because it probably had more to do with their stim start date than anything physiologic. I would have you, I would absolutely 100% start your stim with those numbers that you gave me there. A luteal phase stim start starts in the time period, usually a week or so after ovulation. And we do that especially in folks who have a little lower ovarian reserve, because that may help us to get a more coordinated group of follicles to grow together and to recruit some follicles that we would otherwise lose. So when I saw that, that's what I thought. I think you're in an ideal place. I still would not start progesterone because that's not going to make any difference at all at this point. And also, I don't want to suppress your ovary. I just want to kind of put a little pause in place there. So when you're using estrogen only for timing of your cycle, what that does for us is that it's not unusual that you'll have some kind of cyst like a corpus luteum. But nevertheless, we put some pause on the way the rest of those follicles are growing. And that's really kind of the purpose behind it. Let's see here. Hi, Aaron, who says nice haircut. I appreciate that. Thank you very much. Oh, this old thing, you know. Yes, I got a haircut. If you missed at the top of the show, I said they were actually running a special, and that was you could get all of them cut for the same price. So not just a haircut, I got them all cut. So now I kind of look like Shaggy Dog on the top and Gomer Pyle on the sides, which is different from the mullet haircut, which is party in the business in the front and party in the back. This is Shaggy Dog on top and Gomer Pyle on the side. I hope you like it. Hey, if you've got questions, go ahead and throw them out here. Let's see if we can get to them. But it is 1/2 the hour, which means it is time for something very, very important to me. And that is the 5:30 Fuzzies with Fink. What do we do here? You probably know that going through this fertility process it's a difficult and challenging thing because the end game is unknown. Maybe you have ridden that roller coaster that goes up and down, that jerks you from side to side, that takes you upside down. It shakes your pockets empty for sure, but inevitably it pulls back in the station, and you may not know for sure if you're going to be able to get off that train with a lovely parting gift, and that's a baby. It fosters a sense of loneliness. It fosters fear. It creates a situation that's genuinely uncomfortable because you just don't know how it's going to end. Well, this is the time that we stand together as one community to send out the positive vibes to everybody tonight who needs to know that they are not alone, who needs to know that what they're going through is something that others have been through and have survived it. They have stood strong and made it through the other side, many of whom with babies in their arms, those miracle babies that people were talking about a little earlier. That's what keeps me going, knowing that I can make a difference in some people's lives. But you know what? It's not just about fertility. Sometimes it's about work, it's about relationships, it's about friends, it's about lovers, loved ones, family, it's about school. It's all those places and things that give us the challenges in life that can make us feel alone. And there is nothing worse than feeling like you are alone, even in a crowd of people. So tonight at 5:30, I want us all to send out as much of the positivity as we can to everyone out there who needs to know we're all in this together. You are not alone, and you'll get through it. You really, really will. And that, my friends, is the 5:30 Fuzzies with Fink. Send out the vibes. Let's break the internet with kindness, because there's just not enough kindness in this world. And as I'm fond of saying, as we close the show, tomorrow is a new day and it's full of all new adventures. And so let's look forward to see what tomorrow brings us. Good evening, Reed. Thank you for being here tonight. And Shada says, does it hurt to pause 2 or 3 days to stop the estrase and to start the stim? After that, or you would rather to start now with this high level of E2? Mine was 202. That's okay. You're taking some estrogen, and that's really the reason why. So if you're on a birth control pill to try to coordinate the timing of your cycle, and we really don't prime with birth control pills, just to be 100% clear. What you're doing is kind of suppressing. But if you're on a birth control pill, you really need about a 3 to 5 day washout of that birth control pill before you start on your stim meds. If you are on estradiol alone, and I would say that same thing holds true if you're taking both estrogen and progesterone, because really that's a birth control pill. If you're on estradiol alone, you can take it up through the very day before, sometimes even day of stim start. I usually stop it the day before. So no, I would absolutely not pause 2 or 3 days, because what's going to happen there is that then you're going to start to get follicular growth without the stimulation from your stim meds, and you're going to start to lose follicles. So you stay on it until the day before, and that's when I would stop your estradiol. And don't worry about that E2. It absolutely doesn't matter. They were pushing me to be on a couple more days of estrogen to lower the levels to be a better baseline. No, this is you said it doesn't make sense to you. So you said, no, I think that makes sense, because you are literally doing a luteal phase start, and that's okay. I think the person that was telling you that may just kind of not really fully understand the physiology, and we're thinking you were on a birth control pill, so you should be at a follicular phase kind of baseline, and you're not. This will suit you better. That's a luteal start. So yeah, good call there. It is Roro. Thank you for being here tonight. That's a great name. I really like that name. It is Roro. Let's see, what else was I recently here asked about? One of the things that comes up a lot is the question about diet. Does diet make a difference? Should I be on some specific diet? I know I've got inflammation in my body. Should I be on some kind of anti-inflammatory diet? And if so, what is that diet? What's the best anti-inflammatory diet? Well, you will find as many opinions on that question as you do on people who ask it. So, if you follow, particularly where I used to work, there is a lot of stuff out there about keto and carnivore. Carnivore really kind of being an extension of keto. And does it work? There are people who will swear to you as though it is their religion that if you are eating vegetables, they are trying to kill you, and that and give you all the reasons in the world. And a lot of it does make sense. Keto probably does make sense in many ways. And I understand the thought process behind carnivore. And so if you want to do that, there is no harm in doing that. And frankly, it may just help you. Many people lose weight on keto, and is it anti-inflammatory? Perhaps it is in some ways, but when people also talk about inflammation in the body, the classic thing we think about for inflammation is how heart disease affects us, and that it's inflammation in the lining of the coronary arteries that leads to so-called hardening of the arteries and atherosclerotic heart disease. And cardiovascular disease is the number one reason that most of us are going to die. So, we pay attention to heart health. So as far as heart health goes, they talk about, no, it's not keto carnivore. In fact, that's probably the opposite of what they suggest. They suggest Mediterranean diet. So Mediterranean is very well founded from an anti-inflammatory standpoint. So it just kind of depends on how you want to feel about it. The truth is, as it pertains to fertility, the scientific evidence shows that, sure, anti-inflammatory is probably a good thing, but there is no one particular diet that has consistently been shown to be better than anything else, so much so that we can reliably make a recommendation on science that says this is the reason that you need to be on that diet. So I certainly say keto carnivore, if that makes you happy, if you're comfortable with it. Frankly, I've tried it. I think it's very hard to, it's not really sustainable, at least to me. If you can do it, great. Mediterranean, the one thing that all the diets have in common is that carbs are the enemy. Carbs are the enemy. Carbs are pro-inflammatory. Glucose, sugar, simple carbohydrates, they put weight on you. They cause sugar groups metabolically to attach to other chemical structures in the body, and that can then damage those structures and create further inflammation. So carbs are the enemy. To the extent that you can limit your carbs, I think that's probably a good thing. I think that's probably the best thing. Now, do you have to do it with any certain amount of protein or with X amount of fat? It's up to you. It's up to you. But the most common sense thing that you can do is to limit carbs. So what does that actually mean? Should you count carbs? Well, how many grams of carbs a day? And I'd say I wouldn't do that either, because I don't think that's sustainable. But your body cries out for carbs. It craves those carbs. And so if you can, I say don't have a Pop-Tart for breakfast and a pizza for lunch and a bowl of spaghetti for dinner, because that's a carb heavy day. You're just filling yourself with carbs. And that is a quick way to end up looking like me, which is a baked potato instead of the McDonald's French fry. I think just limit your carbs to the best of your ability. Do you have to eat carb-free crust? No, you don't have to do that, but just don't have pizza every single day, Things in moderation, I think, make sense to me, and I'll tell you why. When you hear someone tell you something that is very extreme, right? That's all or nothing. That you must be on an all meat diet, or nope, you must be on an all vegetable diet. Nope. Those are extremes. They're far ends of the spectrum. And if we know anything from, hey, look at politics, same kind of thing. If you're all the way to the right without any semblance of anything else but hardcore right-wing politics, you're extreme. Same thing goes if you're all the way on the left. You're extreme. What really works is kind of a little bit of a blend of both things. And think about sitting in the bathtub. You can't turn on the hot water all hot water and get in that bathtub. But nor is it particularly comfortable to put on the cold water and sit in that bathtub either. A nice blend of both, and maybe you like it a little more hot, or maybe you like it a little cooler. You're the judge of that, but it's finding the right medium. Everything in moderation. Finding the right medium is really what is kind of what it's all about. But from a diet standpoint, limiting the carbs is really probably the best choice. Hi to Ashes and Indipino Journey. Good evening, Dr. Mark. How are you this evening? Thank you for being here. Angelina, our wonderful cardiac nurse practitioner, says yes, hooray to the Mediterranean diet. I'm curious, did you ever do keto and all that, or did you just kind of stick with Mediterranean? So, in the cardiac world, that's kind of what they recommend. Olive oil based things. You avoid trans fats and so forth. That's just kind of my 2 cents worth there. And the other question that I do hear a lot is, well, what is the best prenatal vitamin? And maybe you've heard me talk about this before, and if you have, you know what? Angela says, nope, Mediterranean all the way. And Dr. Mark, I've been on a Mediterranean diet for 15 years. You see, and there you go. And I appreciate you saying so, because Mediterranean diet is actually sustainable. You can go on that diet and stay on it, and it's not and not feel like you're on a diet or that you're doing something that's strange and weird. I think staying on something like carnivore or being extreme keto, again, to me, it's just not sustainable. And any kind of diet you're going to be on needs to have sustainability, because you have to be able to reward yourself. And Marlena says, registered dietitian here. Love to see it. Okay, Mediterranean it is. Thank you guys for providing that feedback. That's actually very validating, and I appreciate that. Let's see, what were we going to say there? I started to talk about, what is the best prenatal vitamin? I got to tell you, prenatal vitamins are a little bit of a scam. Because I have seen prenatal vitamins advertised on the internet that are, $80, $100, $120 for a prenatal vitamin. And I would ask myself, are they substantively better than the $8 Walgreens or Walmart gummy? And the answer is probably not substantially. Now, you might think, but it's expensive, so it must be better. That's for people who can afford it, and they can afford the best things, and so it must be a good thing. But it's really not, because most of that multivitamin ends up in your urine anyway. So it gives you very, very expensive urine. Where does your urine go? Well, you can answer that question, because you know as well as I do, it's not feeding your baby, put it that way. Some vitamins have a little bit of some special things. Some of them have a special coating. So maybe that's coating, not coating, coating. So that maybe they're tolerated a little bit better on your stomach. Some of them you burp up a little less. Some of them have a flavor to them. Some of them may have a little bit more of some of the B vitamins in them. So supposedly they create a little bit less nausea, or help you treat some of the nausea and vomiting associated with pregnancy. And I'm not sure if choking down a prenatal vitamin is really a great thing to try to help you prevent nausea. More often than not, it causes that nausea. But I think that you get something cheap, you get something you can tolerate, you get something that you like. I do not think that you need to overspend on a prenatal vitamin, because again, most of it ends up in urine. I say that if that vitamin can show you proof that it's going to get your child into Harvard on a full scholarship, scrounge up the money and take that vitamin. But short of that, it really, there's probably not really a big difference between most of the vitamins. In fact, really, truly the only thing that a prenatal has that's different from a regular multivitamin is, well, sort of number one, I would say that there's often a little less vitamin A in a prenatal vitamin because too much vitamin A can be toxic to a pregnancy. And really, the most important thing a prenatal needs is the folic acid or folate, and that's 400 micrograms of folic acid. Some of them have 800, some of them have 1200 or 1000. All you need is 400. If you have more than that, you're really probably not storing it so much, or for most people, it's just not all that important anyway. It doesn't really truly make a difference. The only people in whom we say that having more folate or more folic acid is beneficial is in the folks who have had a history of spina bifida or of an open neural tube defect. And that's a particular spinal type of birth defect. And those folks, we say 4,000 milligrams of folic acid is what you need. And that's what we recommend in that scenario. But for most people, 400 micrograms, which is not a lot of folic acid. You're supposed to be on it 3 months before conceiving. And so that's why if you go for a checkup to your gynecologist and you're not using any kind of birth control, they may tell you, well, look, you really should be on a vitamin with 400 micrograms of folic acid, because if you're having sex, you're at risk for getting pregnant. If you're not trying not to get pregnant, then you are trying to get pregnant. You know what I'm saying? Good evening to Mrs. Vince in Navarre, Florida this evening. Welcome to the Gulf Coast from Kentucky. I hope you guys are having a good time over there on the beach. Independent Journey asks, can a C-section scar cause recurrent implantation failure, and what would you look for? So that C-section scar, if it grows into the cavity of the uterus, is what's known as an isthmocele. Isthmocele. And it is not a common cause of recurrent implantation failure. What you would look for is that, oftentimes on ultrasound, you can see where that C-section scar is. And in most cases, the C-section scar is in a part that's known as the lower uterine segment. And the lower uterine segment actually turns out to be in the top part of the cervix. It's not actually within the uterine cavity. And your pregnancy should not be trying to implant in the cervix, because there's no endometrium there. It should be planting inside the uterine cavity itself. So for that reason, that C-section scar is not a common cause of implantation failure. One of the things that is incumbent in the workup of recurrent implantation failure is looking inside the uterine cavity, placing a camera inside to take a look, and that's called a hysteroscopy or hysteroscopy. To scope is to look inside the hystero or the uterus. Well, it would be pretty obvious when you look inside the uterine cavity if there's still a defect in the cavity where the C-section was. So in other words, if for whatever reason the incision that was made into the uterus was a little higher and into the part that's known as the myometrium, then that can interfere with the uterine cavity later on. But otherwise, lower uterine segment is actually in the upper portion of the cervix and really shouldn't be involved. Now, recurrent implantation failure is one of the more challenging things that we have to deal with, because there is it's hard to, especially when you've got good, beautiful, perfect embryos. You've got those beautiful embryos and you keep doing embryo transfers and they're not sticking. It's heartbreaking. It's a very hard thing to go through. In most cases, recurrent implantation failure typically has more to do with the embryo than it does the mom. And I'd say greater than 90% of the cases, the problem is still an embryo problem. But we occupy so much of our time looking at mom, trying to find some mom issue that could be here. And you want to look under those stones. You want to turn over those stones and look underneath and, make sure that you're not missing something. And that makes all the sense in the world. But in reality, most of the time, it's going to be an embryo issue. Now, there are a number of interventions that we can make. First of all, I will tell you that the evidence shows us that when we keep putting in embryos and they don't stick, every year at the American Society for Reproductive Medicine, I go to the workshop on recurrent implantation failure, because really, to me, it's the most heartbreaking thing. You've made beautiful embryos, and by all rights they should be sticking, and they don't. It's as much a heartbreak to us. It's extremely frustrating, and every year looking for some magic, looking for something new that tells us, oh, okay, now we've discovered this immunologic function that if only we flip that switch, then we're going to be able to change the outcome. But what they say over and over again is that the evidence shows that placing more embryos inside is typically going to get you the pregnancy that you want. Even if you've had recurrent implantation failure, eventually it's going to work. Now, to me, I don't find that to be a very satisfying answer, because there's a finite number of embryos, and to say, hey, let's just do the same thing and hope for a different outcome. That to me is the definition of insanity. I don't like to do that. So we like to try, if we can, to find other things. And there are some immunologic things. So for example, the medication known as tacrolimus, that is my number one go-to for folks who are have recurrent implantation failure. Tacrolimus, or Prograf, taken 1 milligram 3 times a day, or 1.5 milligrams twice a day. It's easier to do. There's a 1 milligram tablet, there's a 0.5 tablet. So if you want to do 1.5 twice a day, you got to get 2 prescriptions. But the 1 milligram tablet 3 times a day, because less than that probably doesn't work. And I want to stress that there are some programs that are still using old protocols, which are sort of, well, we can see if this works. And that's a 0.5 milligram twice a day. That really was shown not to do anything. It's 3 milligrams a day in divided dose is said to make a very significant impact on the immunologic function that may be keeping your pregnancy from implanting. And what is that? What does that even mean? What is it? Well, we have 2 types. There are 2 particular types of a particular type of immune cell called T helper cells. There's a type 1 cell and the type 2. The T helper 1 is the cell that sounds off all the alarm bells. It goes crazy. The sirens are going off, and it's going, think about, let's say you get a splinter in your hand here. Alarm bells are going off. It's going crazy. Oh my God, we've got a splinter. We have an invader. We have to do something about this invader. And those T helper type 1 cells are going nuts. Whereas the type 2 cell says, hey man, take it easy. We got this. We have antibodies that know how to deal with this. Easy does it. We don't have to worry. We got this. Well, if your type 1 cells are going nuts and they're just too loud, then they can really try to attack that foreign body, be it in your hand there, or maybe it's even your pregnancy. Maybe it thinks your pregnancy is an invader. And those T helper 1 cells will go nuts and attack it. Whereas the type 2 cells say, yeah, man, take it easy, calm down. So what tacrolimus or Prograf does is that it balances out that ratio between type 1 and type 2. It evens out the score between those 2 types of immune cells. And was shown to have a very significant difference in folks with recurrent implantation failure. Now, you can do a test, not super reliable, but you can do a test to measure your type 1, type 2 cells. But why do you need to do that? Because that test may cost $1,400 in the laboratory, as opposed to tacrolimus, which probably cost $8 from the pharmacy and really shouldn't have much in the way of side effects. So in folks with that particular history, I start tacrolimus at the time of progesterone start, or if you're doing a natural or a modified natural cycle, from the time of ovulation. And I continue it through 12 weeks of pregnancy, even in folks who have had not just recurrent implantation failure, but also recurrent pregnancy loss, because we know that the immune system can be a factor there. So I do think that that's a very realistic thing to do, and the evidence really truly supports it. A lot of people ask about, well, what about natural killer cells, NK cells? Well, they sound so scary, don't they? Well, ma'am, your natural killer cells are going wild. And that's like, oh, I don't want that. I don't want that. How do you make them turn off? And so there's things that you do about that. But, to be honest with you, these NK cells or natural killer cells are very controversial, because testing them is resplendent with inaccuracy. You can test the number of cells, and it may be that your number is normal, but the accuracy, the activity rather, the number of cells is normal, but the activity of the cells is wrong. Maybe it's too much, maybe it's too little. Or you can test the activity and the number and get some thing back that tells you something that may not correlate at all to the natural killer cell activity that's happening at the level of the uterus in the endometrium. So that's a hard one too, but tacrolimus is a real one that is an easy intervention that I think is very, very useful for everybody who has that history. And really, frankly, anybody who has done an embryo transfer and wasn't successful with it, I put them on tacrolimus, because there's just no good reason not to in most people. Dom Clark, good evening. And V. Reese, hi. Marie, nice to see you there. Jasmine, hi. And Heavenly Joy, good evening to you. Thanks so much for being here, V. Reese. You're over there as well, I think. Weren't you over here? Did I see you twice? Yes, I certainly did. Folks, we're going to run out of time here tonight, but I sure hope that you will join me next week at 5 o'clock Central Time, 4 in the mountains, 6 on the East Coast, for Fertility with Fink and Friends, because I am Fink, you are friends, and this is the place I hope you will enjoy being just as much as I do every Tuesday night. Send your questions along, bring them with you. Love to talk about all these things that are important. And until next week, please know every step forward with love, every step forward with kindness, and every step forward with hope, because tomorrow is indeed a new day, and it is full of all new adventures. This fertility business is not the book of your life. It's just a chapter. And what are we doing here? We're here to rewrite it together. So until next week, Dr. Randy Fink in Pensacola, Florida, saying